R1, R2. Anyone, it is very simple case. We need the spot diagnosis. Anyone? Very easy case.
Can I talk, sir?
You can talk.
Frontal view of mature skeleton showing hyperlucency of the right lung with multiple fracture at the lower lips with IC4 rib fracture. With the hyperlucency of the right hemithorax suggests pneumothorax with the collapse of the right lung.
Which rib fracture are you seeing?
4, 5, 6, 7.
Anterior or posterior?
And anterior rib fracture.
Anterior fracture. Are you sure? No, there is a fracture.
I see stepping those ribs. Like step, I don't know.
You mean this one here?
Doctor?
You mean this one here?
Yes.
This one?
Yes, what?
These are not a fracture. These are
not a fracture.
No, these are posterior cartilage. You see here on one side, and this is the posterior cartilage. You see all the same. Okay? These are the end of the...
Okay.
On the... Okay. These are posterior cartilage. And you said, what is that diagnosis?
Right pneumothorax.
Right pneumothorax.
The collapse.
Okay, with collapse.
Right lung.
You should mention the right pneumothorax in the various scenario.
Second, doctor.
Second, you should mention this is tension in pneumothorax. Pneumothorax لحاله, it is not enough. It is pneumothorax alone, it is not enough. This is a tension in pneumothorax. Why? Because almost all the lungs on the right side, it is almost collapsed. Okay, and we need urgent treatment. What is the urgent treatment of this patient? What is the urgent treatment?
Decompression by...
Yeah, we need decompression of the right pneumothorax.
Thoracic.
Yeah, why chest tube or whatever. Okay. Okay. Now this is very simple case. What is there any differential diagnosis in this case? Is there any differential diagnosis? R3, R4? Is there any differential diagnosis?
I think no.
Actually,
Sjögren's syndrome.
Huh? ايش هو؟
Sjögren's syndrome.
No. Sometimes
could be large bulla.
Sometimes very giant bullous. It is involving the whole lung. Sometimes you cannot differentiate between the tension in pneumothorax and the giant bully if it is involved the whole hemithorax. Okay, so this is the only differential diagnosis, but it is very rare. It is very rare. Okay. We move to the second case. Okay, you can start. Anyone can start? Anyone who wish to start? It is simple case. Anyone? It is simple case.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
I see that there is CT scan of the vertebra. There is a fracture of the anterior of the body of the vertebra.
There is a fracture of what?
Of the anterior part of the vertebra involving the vertebral body.
Involving the.
Or if this is, it is atlas vertebra.
This is actually the second vertebra. What is we call it? The second vertebra?
Yes.
What we call the second
C2?
Axis.
Axis.
Axis, okay. Okay, this is the second vertebra. What you see, again, look again. What you see, there is a fracture line here, okay. Yes. But the fracture line, it is, and here, this is fracture line and fracture line bilaterally going to the what? Anyone? You see here?
Pedicle?
Going
both
to the
pedicle?
pedicle lamina, okay. Going to the pedicle lamina. What we call this fracture?
Hangman fracture.
Hangman fracture. What is hangman fracture?
It's a fracture of the body of C2.
Fracture of the body?
Pedicle.
Are you sure?
But a
pedicle.
It is
fracture.
It is pars interarticularis fracture, or traumatic, we call it traumatic spondylolisthesis, or traumatic spondylolisthesis involving the pars interarticularis of the C2. Okay, this is the pars interarticularis fracture, and it is fracture about 4 to 7%. Okay, and the patient died from this fracture. What is the cause of death in this fracture?
vertebral artery ischemia.
Vertebral artery ما بتسوي death يعني. بصير vertebral artery ischemia, yes, but what is the cause of death in this fracture?
Spinal cord rupture?
No.
Hyperextension.
It is some sort of hyperextension, but what is the cause of death?
Basilar invagination?
No, it is the asphyxia. The asphyxia, it is the cause of death of the hangman fracture, okay?
قبل ما نشرح
Okay, how many, what is the classification of the hangman fracture? Anybody knows? Anybody knows any classification of the hangman fracture? Here, this is the classification, some of the classification, and we see this is type 1, this is type 2, okay, type 1A, type 1, this is type B, type 1A and type 1B, and here this is, it is depend on the depend on the distance of depend on the distance of the displacement. Okay, this is depend on the distance displacement, and with the distance displacement, it is we see the if it is less than 3 millimeter, it is type 1, and if it is more than 3 millimeter, it is type 2, and with type 3, it is a fracture, it is horizontal fracture with sometimes vertical orientation, and in the type 3, in the type 3 also, it is bilateral facet joint dislocation. Go and read more about the classification of the hangman fracture. Okay. So this is Bow's interarticularis fracture involving the C2, and it is hangman fracture, and we see here different types of hangman fracture depending on the displacement and the orientation of the fracture. Okay, next case, simple, very simple.
PCO.
من وصف. Okay, we want description, and if there is any diagnosis, you can put the diagnosis, and if there is any sign, you mention the sign. What is that? What is the procedure here? What is the procedure?
Transvaginal ultrasound.
Transvaginal ultrasound. What you see?
Selected image show maybe enlarged. I don't know the measurement with enlarged ovary.
Enlarged
with
ovary.
multiple
What is the striking things here?
Echogenic central stroma.
Okay.
With the surrounded with the small follicle arranged peripherally.
Small follicles arranged. The follicles arranged in the peripheral fashion of the ovary. Okay.
Of the ovary.
Okay.
Right. Picture goes with the polycystic ovary.
Picture goes with polycystic ovarian disease. What is you remember the sign here or not? What is the sign?
I don't wallah.
You don't. Anyone remember
the ring
this
of
sign?
pearls? The ring of pearls.
No, it is string of bears sign. زي المسبحة. Okay. زي المسبحة. It is المسبحة. It is in the periphery. This is the strings of bear sign. Okay. This is the sign. So what are the criteria for diagnosis of polycystic ovarian disease? You should have criteria. Okay, what are the criteria?
Multiple follicles of same size, or no dominant follicle.
No dominant follicle. Okay, very good. These are the criteria, and this is the string Beer's string sign, and okay, normally how many follicles we can see?
Nine.
Okay, we see sometimes more than 12 follicles. Okay, for the diagnosis. Okay, this is and the follicles, as you said, it is in the same size and between 2 to 9 millimeter. okay?
2 to 9 millim, and the overall volume of the ovary is more than 10 milli.
And the ovary large, it is large, okay? Okay, these are some information about polycystic ovarian disease. بهمنا احنا كسونوغرافر or radiology. The ovary is a large and peripheral distribution of the ovary follicles within normal size اللي حكينا between 2 and 9 millimeter. Okay. Okay. Any question on the polycystic ovarian disease? Okay, we move to the next case. Anyone in the next case? Anyone for the next case? Anyone in the next case? It is easy. It is easy.
Diverticulosis.
Okay, what is the procedure?
CT scan axial section.
CT
through the
scan.
pelvis.
Okay, selected image of CT scan with contrast or without contrast?
Contrast.
With contrast, very good.
Showing outpushing.
Showing out
through the wall of the large bowel. Sigmoid.
Which part of the large bowel?
Associated with some area.
Which large bowel? Large bowel? Huh? Which part?
Sigmoid.
Sigmoid, very good.
Sigmoid.
Okay.
Associated with the area of fat surrounding and sign of inflammation. So go picture suggesting diverticulitis.
You see multiple outpouching in the sigmoid, but we don't see actually fat stranding. Okay, we don't see fat stranding. Okay, actually, we don't see fat stranding in the sigmoid here, and this is only simple diverticulosis. Okay, simple diverticulosis. Okay, what is the common site of diverticulosis?
Sigmoid.
Sigmoid and descending colon. These diverticulosis are true diverticulum or false diverticulum?
False.
False diverticulum. Very good. It is false diverticulum, and it is herniating of mucosa through not a real defect through the vessels vasa recta in the because in or due to increase intraluminal pressure. Okay, this is what is the most common symptoms of the diverticulosis?
Pain, abdominal pain.
Can be abdominal
lower GI
pain. Huh?
Lower GIT bleeding.
It is lower GI bleeding. The GI bleeding from which side? Right or left?
Left.
Left side. Okay. From the left or right? Anyone?
Left.
Huh? Anyone? Left or right? The bleeding
Left.
from actually the common site, it is sigmoid descending column, but the
Left.
bleeding from the right side. Okay, the bleeding it is common from the right side, as I remember. Check it. Please check that for that. Okay. Okay. We move to the next case. It is related to the same pathology, but little bit more complicated. What is this? Okay, we need any volunteer for this case. Volunteer for this case. As the previous case, we see diverticulosis, and what else? What else we see with the diverticulosis in this patient?
Thickening of bowel wall.
Thickening of the bowel wall.
And collection.
And collection. Okay, it is big collection or small collection?
Pocket of collection.
Okay, we have collection and some stranding as we see here in that area. Okay, and some stranding in that area and some collection around the colonic wall. And this is what we call the diagnosis.
Diverticulitis.
Diverticulitis. Very good. Okay, diverticulitis. Okay. What is, you know, any staging for diverticulitis?
Actually, no, sir.
Okay, anyone knows any staging for diverticulitis? Diverticulitis can be staged into 4 stages. Stage 1A, it is a phlegmon, only you see the inflammatory changes with pericolic or perimesenteric abscesses, and we have in stage 2 we have pelvic abscess. It is walled, you see well defined walled pelvic abscess. And stage 3 it is with peritonitis, and stage 4 with fecal peritonitis. So this one, it is between stage 1 and stage 2. And the treatment of stage 1, stage 2, it is usually conservative with antibiotic, and the treatment of the stage 3, stage 4 with surgery. What are the common complications of the diverticulitis? The common complication of diverticulitis?
Fistula.
Fistula. Where the commonest site of fistula?
Fistula.
What is the commonest site of fistula?
Fiction.
Where?
All over the cycle. All over the cycle.
Bladder.
Okay, between the
colovazycal
rectum and the bladder, colovazycal fistula. We have also another type of fistula, colovaginal fistula.
Bladder.
Okay, and coloenteric fistula and colocutaneous fistula, and sometimes we have adhesion and we have a small bowel obstruction, and also one of the complication, it is phlebitis, and sometimes rupture of the diverticulum will give us to pneumoperitoneum. These are some of the complications of the diverticulitis. Any question on diverticulitis? Okay, we can move to the second case. Okay, and we have a problem in the internet. Okay. Okay. سامعيني؟ الو
خطيه.
سامعيني؟ سامعيني؟ سامعيني؟
ايه دكتور.
اوكي، شايفين الشاشة ولا مش شايفينها؟ شايفين الشاشة ولا مش شايفينها؟ لأن قطع النت. شايفين الشاشة ولا مش شايفينها؟
نعم نعم استاذ.
شايفين الشاشة بس مع الجواب.
مع الجواب. طيب خلينا نشوف. اوكي مش مشكلة. خليني اسكر انا اشوف. اوكي. مع الجواب هيك. اوكي خلينا نشوف كيف نسوي. اوكي هسا كيف؟ هسا الشاشة كيف؟
تمام دكتور.
مع الجواب
تمام.
ولا بدون جواب؟
لا بدون جواب.
Okay. Okay, we finished this case. This is diverticulitis with some phlegmon with the small thickening of the wall, and we have a small enhancing area suggestive of the small abscesses, and we have stranding here. Okay, and we move to the second case. This is the second case. Okay, anyone on the second case? Anyone on the second case?
دكتور احنا already شفنا الحل بس
مش مشكلة خلينا هسا
عم
مبين ايش مبين عندكم؟ ايش مبين؟ مبين الحل ولا مش مبين الحل؟
لا مش مبين حاليا.
طيب مش مشكلة. حتى لو شو اسمه مش مشكلة. اوكي what you see؟
midline hyper intense lesion, pericallosal, hyper intense on T1 and T2. Follow the fat signal in all sequence. So the diagnosis is callosal lipoma.
Pericallosal lipoma. It is suppressed with fat or not suppressed with fat? Is there any image here with fat suppression? Any image with fat suppression here?
Spare, yes.
Here there is
T2 spare.
Yeah, it is spare. It is spare fat suppression, and you see the fat. It is black as the subcutaneous fat. Okay, so this is pericallosal lipoma, and what are the components of the corpus callosum?
Genio, body and splenia.
Okay, here the spleen, which part it is could be missed? Which part?
Splenia.
Splenia. splenium, it is not well seen, as we see here. It is not well seen, the splenium. This is the geno, this is the body, and the splenium here, the splenium, it is not well seen, so could be missing. Okay, so this is it is what we call this. It is a genesis or dysgenesis.
Dysgenesis.
Dysgenesis. Okay. Okay. Type. How many types of lipoma, pericallosal lipoma, you know?
Two type of pericallosal lipoma.
Huh? How many types? Radiologically, I mean.
Two types.
Two types. Very good. What are?
Two types.
What are the two types?
Tubulonodular and tubulonodular and curvilinear.
And curvilinear. Okay, very good. Very good. We have two types, tubulonodular and curvilinear.
Curvilinear.
And the difference between them, what is the difference between them? The thickness of the lipoma, it is 1 centimeter in the curvilinear and about more than 2 centimeter in the tubulonodular type. Okay, so this is the how we can
tubulonodular
more than 2 centimeter. Okay, and curvilinear is less than 1 centimeter. Okay, how we can what is the how we can differentiate lipoma from dermoid cyst? How we can differentiate lipoma from dermoid cyst?
Homogeneous. The lipoma is homogeneous because it's a pure fat. It's a pure fat. Dermoid is heterogeneous because contain calcification, fluid, and fat.
The most important is the lipoma. It follows the sequence, all the sequence of fat in all sequences. Dermoid sometimes it, as you said, it is heterogeneous and mostly it is in the T1. It is hyper intense. Okay, mostly in the T1 it is hyper intense. The dermoid, okay, because of more cholesterol. So this is some information about the pericallosal lipoma in patient with dysgenesis of the corpus callosum. Okay. Okay, we move to the second case. Next case. Anyone for next case? It is small. It is easy. Anyone for the next case? It is easy.
Triquetral fracture.
اوصف حاولي تعلمي على الوصف. اوكي.
Okay. PA view, multiple views, PA, oblique and lateral.
Okay, very
plain
good.
X-ray of the hand and wrist.
Okay. What you see?
Showing a fragment of bone on the dorsal aspect of the carcass on the lateral view.
On the lateral view, what else you see also? What else you see?
There is a malalignment of the carpal bone on the lateral view.
No, it is okay, alignment. You see soft tissue swelling here. You see here, you see here. You see this is soft.
Yes.
Yeah, you see.
Yes, yes, yes.
You see soft tissue swelling. Okay, overlying the avulsion fracture. Okay, this is the avulsion fracture here. خليني أكبره. Okay. This is the avulsion fracture, and this is the soft tissue surrounding the avulsion fracture on the dorsal aspect of the wrist. Any sign for this?
Pooping duck sign.
Pooping bird sign.
Okay, very good, very good. And this is the, let us remove this one, and this is the pooping duck sign, and this is the fracture here. Okay, and this is the duck here, and this is the what is this one? This is the scaphoid, and this is the neonate. Okay, and this
Triquid,
is the,
capitate.
And this is the scaphoid,
Capitate.
and this is the neonate, and this is the fracture site. Okay, if we go back, let us. Sorry.
There's soft tissue.
What is this sign here? You see here there is some fat bed. Okay, what we call this sign here?
Hashim fat bed.
Huh?
Pronator.
Very good, very good. This is a pronator fat bed sign, and due to due to edema or effusion in the pronator muscle. Okay, so you see here soft tissue swelling, and here the fat bed. Okay, so this is tricuteral fracture, and with the tricuteral fracture we have Bob sign, as we said, Bob duck sign. Let me remove this one. Okay, and this is the triquetrum, and one of the causes of the fracture is avulsion. It is ligamental injury. With the ligamental injury causes some fracture or avulsion fracture of the triquetrum. Okay. Okay, next case. Anyone for next case?
Pneumoperitoneum.
Could be chiladitis.
Again, I try to what is the procedure?
Describe.
I'll describe the procedure and what you see. Okay, and the finding, and then we need the diagnosis or differential diagnosis. Okay, what you see here, what is the procedure? It is simple. Okay, chest X-ray. What you see? Okay,
Frontal chest X-ray.
Okay.
Frontal chest X-ray.
Of the child. Okay, what you see? What you see?
Overinflated chest.
Huh? What you see here?
Overinflated chest, sir.
Showing gas lucency overlap.
We have gas, abnormal gas lucency under the right hemidiaphragm. But what?
Under the right hemidiaphragm.
Okay, what the characteristic of gas here? Is there any characteristic of gas?
Yes, there is hostera
Crossing
crossing
there is hostera
crossing
as we
through
see
the gas
here.
shadow.
We see here, there is hostera of the gas. So this is not in pneumoperitoneum, okay? What we call this
Yes.
is pseudo
Chaldati.
pseudo-pneumoperitoneum and Chiriatides sign, okay? Or Chiriatides colon or sign, whatever you like, okay? And this is the lateral view, okay? Which one is the
Lung brace.
right hemidiaphragm? Which one it is the left hemidiaphragm?
The higher is the right side.
The higher is the right, and
The lower is the left, which is obliterated partially by the heart.
which it is obliterated partially by the. Okay, very good. Okay, we move to the next case. What you see on this patient? It is simple. Anyone for this case? Anyone?
Plain X-ray of the lateral view of the ankle,
Lateral view of the
showing
ankle.
increased heel pad thickness.
Increase fat bad thickness where?
Heel pad.
Under the calcaneum.
Under the calcaneum. You mean here, huh? Huh?
Yes.
You mean here, okay.
Yes.
What else? If I told you this is not the pathology, look for something else. What? You see here the map. You see the bump here. Okay, here. You see that?
Yes.
Which tendon here it is inserted?
Achilles tendon.
Achilles tendon, very good. And you see some soft tissue swelling of the insertion of the Achilles tendon. In other words, the Achilles tendon, it is thickened.
Thickened.
Tendonitis.
Okay, and what is this here?
Hole?
It is not this one. It is normal or abnormal?
Hagland's syndrome.
Okay, very good. But what is this? This looks like bony exostosis. Looks like bony exostosis on the superior aspect of the calcaneum. Posterior superior aspect of the calcaneum. And what we call this fat here?
Hagland deformity.
Hagland.
This is totally Hagland deformity. Hagland deformity. But what we call this fat here?
Triangle.
This is
retrocalcaneal.
Retrocalcaneum. We call it gagger fat. Okay, gagger fat band. Okay. إذا ملاحظي خليني أسوي remove for this. You see here the fat. It looks like dirty fat. You see here some soft tissue swelling here, some مظبوط ولا لا? Not the whole fat. It is clear. Okay, so some dirtiness of the fat, swelling in the Achilles tendon and the bony. This is, as you said, this is Hagland deformity. We have three components of the Hagland deformity: Achilles tendinopathy, as we see here, retrocalcaneous bursitis. We see some dirtiness of the gagger fat, and also we have some here bony abnormality, posterior, superior aspect of the calcaneum. So this is the hard lung deformity. And the cause of this, what?
High heels.
Okay, very good. This is the cause, okay? This is the cause of this, okay? Sometimes we can measure the severity of the hard lung deformity or syndrome by measuring this angle, but no need. If you are interested, you can go and read about this, okay? So this is hard lung deformity. We have traits, 3 traits: tendons, tendinopathy, Achilles tendinopathy, and exostosis or bony spare, whatever you like, and retrocalcaneal bursitis. And this, let me remove this one. And this is what we see in the plain film. This is the tendinopathy of Achilles tendon, thickened, and some fluid in the bursa, retrocalcaneal bursa, and the bony deformity of the posterior aspect, posterior superior aspect of the calcaneum. Okay. This is but also hard lung deformity. Also, this is another patient here with tendinopathy, with calcification, and deformity here. And here, this is the, you see here the dampness of the fat in gargle fat, and compared with the upper part. This is the soleus muscle here, and you see the fat, it is here clear, and the fat here, it is not clear. So this is, we have 3 components of hard lung deformity or disease or syndrome. Okay. Any question on this, huh? Okay, we can move to the...
Doctor, in this picture, it is calcification tendon?
In the tendon, yes. It is calcification in the tendon, okay? اوكي. ممكن فرجيناكو هاي الصورة قبل هاي مرة، but اوكي، التكرار بيعلم الشطار، ما في مشكلة. What we see here.
Sir, there is no picture.
ايش هو؟
يعني سوري ماكو صورة، ماكو كل شيء.
ما في صورة؟
لا في لا في موجود احنا.
إذا موجود عندنا
يمكن عندي ماكو.
عندك مش موجودة، في مشكلة بجوز عندك. موجود الصورة؟
اوكي
بقية؟
موجودة حكي
موجودة. What we see here.
Bilateral enlargement of the muscle belly of medial rectus.
Bilateral enlargement of the belly of the medial rectus muscle. Okay, this with what?
Thyroid ophthalmopathy.
Consistent.
Sparing tendon.
Sparing the tendon. هي حكت belly of the muscle. It is okay. في شيء تاني معها؟
Exophthalmos.
Okay, we have exophthalmos, bilateral exophthalmos.
Exophthalmos.
Okay, we have bilateral exophthalmos and enlargement of the belly of the medial recti muscle. Okay, what we call this sign?
Coca-Cola.
Pepsi.
Coca-Cola bottle.
Coca-Cola sign. This is the Coca-Cola sign. Okay. Okay. Which muscle is involved? According to the most common muscle is involved is
inferior rectus. I am slow.
I am
inferior
slow.
وميديا superior.
inferior rectus بعدين medial rectus. I am slow. بعدين ايش superior وبعد lateral rectus. This is the least involved of the lateral rectus muscle. Okay. Okay, very good. This patient,
infant,
this patient, this is child,
dilated bowel loops,
this is child. What we see with this child?
then abdominal X-ray,
علي صوتك. Then abdomen X-ray. Okay. What you see? What you see?
Okay.
Okay, what you see?
Okay, I'm presented with a frontal radiograph of abdomen of immature skeleton, show evidence of opacity, soft tissue opacity occupying the mid and left upper part of the abdomen, causing deviation of the bowel loop, especially the transverse colon, more inferiorly.
Okay, very good. Okay. So
there is no differential densities within the mass.
No differential density within the mass. Okay. Okay. What you need? Okay. What's your recommendation?
I recommended to know the history of the patient, the age, and next step is axial CT scan. يعني CT scan.
Okay. Ultrasound, then CT scan. Okay. We have CT scan. This is the blame film of this patient, but this is the scout of the CT scan. Okay, where's the mass? You see the mass or not?
Okay, any calcification? I see some calcification within the mass.
Calcification. This is contrast. This is contrast. There is no calcification of the mass, and this is the mass here.
This is the okay.
Okay, this is the mass here. This is the stomach, and this is push the stomach anteriorly. Okay, and these are contrast in the. This is a scout. Actually, this is a scout of the CT scan, the lateral scout of the CT scan. Okay, and this is the CT scan of this patient. Okay. Okay.
Can I continue?
Yeah, continue.
Okay, I'm presented with multiple axial section CT scan, post-oral and IV contrast at the level of the kidneys. There is a large mass causing mainly centered on left suprarenal region, causing compression of the left kidney more posteriorly and compression of the bowel loop anteriorly. The mass is heterogeneously enhancing, crossing the midline, encasing the aorta, and mild elevation of the aorta from adjacent vertebrae.
Okay. بعد في شيء تاني؟
Ascites. Some free fluid, pockets of free fluid seen.
Okay, free fluid seen in the abdominal cavity. Okay. And here, okay.
Encasing the blood vessels.
And encasing of the blood vessels. Very good.
So,
okay.
Crossing the midline.
Yeah, it is a crossing
encasing
the midline.
And cause elevation of the aorta, mild.
Okay. Here, this is encasing the renal artery. Okay.
Neuroblastoma.
Okay. Okay. Liver.
So my top of differential diagnosis.
Liver is involved or not involved here?
Nothing.
I don't see any obvious lesion, but some hypodensity seen in the right hepatic lobe.
Okay, in the right hepatic lobe here there is a density.
Yes, more anteriorly.
Okay. Okay.
So my top of differential diagnosis is a neuroblastoma with hepatic metastasis.
With hepatic metastasis. Okay. Sorry. Okay.
Yeah.
Okay. What is if there is hepatic metastasis, what we call the stage here?
Excuse me, sir?
If there is hepatic metastasis, what we call,
yes.
What is the stage here? Stage H.
Yes.
2S.
4S.
4S, okay. Stage 4S. Stage 4S, okay. But should be special if it is 4S. If we call it, the patient should be under 1 year, okay? If the liver metastasis, what we call the syndrome, you remember the syndrome? Anyone?
No.
If there is hepatic metastasis, we call it Bieber syndrome, okay? Bieber syndrome, okay? And if there is skeletal metastasis, these are MCQ questions. We call it if there is a skeletal metastasis, Hodgkinson syndrome, okay? The most important, you should know association of the neuroblastoma. What are the association with the neuroblastoma? Any disease can be associated with the neuroblastoma. علي صوتك اللي بحكي.
Syndromes?
Could be syndromes, could be diseases. Neurofibromatosis, one can be associated with the neuroblastoma.
Wager syndrome? Wager syndrome?
Wager, what is Wager? Wager اختصار لإشي مش؟ Wager اختصار لأكثر من شغلة. And the association, it is the big with Redman syndrome, Di-George syndrome. What is Di-George? Di-George syndrome, what is that? Absent?
Thymic absent.
Thymic absent, okay. And Hirschsprung disease and the neurofibromatosis. These are some association with the neuroblastoma. Okay. Okay. Could be this calcification. Oh, sorry. Could be this calcification or enhancement here.
Floating aorta.
This is aorta, anatomical position of aorta.
Okay. And this one?
Mesenteric
vessel.
Mesenteric vessel. Very good. Okay. Okay. This, how much the calcification with the neuroblastoma come?
85.
More than 80%.
More than 85. It is about, okay. Okay, very good, very good, very good. We move to the next case. Maybe this is the last case. Okay. What we see here, this is okay. Okay, this is الجواب موجود ها. Okay, الجواب موجود. We have what we have here. Okay, forget about this one. Okay, centrilobular emphysema. Forget about this one. What we see?
Cystic change of lung parenchyma.
Cystic changes of lung parenchyma. Which part of the lung it is involved?
Secondary pulmonary lobule.
Secondary pulmonary lobule. Okay, we have cystic changes in the secondary pulmonary lobule. For example, this one. Okay, and the cystic changes involving the center of secondary pulmonary lobule. Okay, and as we see here, and we call it centrilobular emphysema. And this one, that lobule, it is that lobule, it is completely distorted. What we call this here?
Panlobular.
Panlobular. And here, what the type of emphysema here?
Paraseptal.
Paraseptal emphysema. So in this image, we have centrilobular emphysema, and we call it, this is the central lobule, for example this one, and we call it dot sign. Okay, dot sign. And we have panlobular completely distracted secondary pulmonary lobule, and on the surfaces, either on the pleural or mediastinal surfaces, we have the paraseptal emphysema. Okay, we can take another case. Okay, we will take another case. This is the last one. Okay, this case, patient with trauma. Okay, what we see in this patient with trauma? What we see in this patient with trauma?
Joint effusion.
Pleural effusion in this lateral X-ray.
Joint effusion.
Joint effusion. Okay, we see joint effusion on this lateral X-ray. Okay, you see any fracture?
There is chip on the posterior aspect of the distal femur.
Posterior aspect of
distal femur.
Distal femur. Okay, I will give you the AB view. Oh, sorry. Any fracture? Any fracture?
Second?
Huh?
Second fracture? Second fracture.
No. Okay, I will give you magnified view here.
Fracture of the tibial eminence.
Okay, you have
fracture of the tibial
here.
eminence.
You see here, there is a fracture here. Okay. Okay.
Yeah, that's fine.
This is the fracture line. Okay. And this is the magnified view. You see the fracture line here. Okay. And this is the confirmation with the CT scan. This is the magnified view, okay, of that area, and also, sorry, this is the fracture line with the CT scan, okay. So what is the this is tibial plateau fracture or what? This is a tibial plateau fracture or not?
Yes.
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 This is a tibial plateau fracture or not? We can consider the tibial plateau fracture.
Yes, yes, tibial plateau fracture.
Okay. Okay, we have a classification of the tibial plateau fracture. Okay, anyone remember that?
Scar.
Okay. Okay, we have.
This is type 1.
We have, this is the, sorry, this is the classification of the tibial plateau fracture, okay? And this is consistent with type 1. Very good. اوكي سوري فانقطاع النت معكم اليوم، ما بعرف شو السبب، بجوز النت ضعيف عندنا صار. اوكي ان شاء الله نشوفكم الاسبوع الجاي ان شاء الله، وتصبحون على خير ان شاء الله.
شكرا جزيلا دكتور.
اوكي
شكرا جزيلا.
عفوا.
شكرا. بارك